Um, yeah. Uh, Good morning, everybody, I guess. And welcome to the session. I don't know, I didn't understand anything before, so I'm just going to welcome you again. I'm going to talk about Praise You, which is a new project from the EIU, or supported by the EIU as the main contributor. And it is about smart early detection of prostate cancer. And I'm going to talk about the past because that's important to understand why Praise You is there and why there's a push for PSA screening. I talk about the present, what is happening right now in terms of trials. And then I'm going to talk about the future of early detection, which means I'm going to talk about Praise You. And So I chose the skiing theme for this whole presentation because I started with the long road of prostate cancer history, which is a good icon, I think, the mountain. So I'm going to talk about history of prostate cancer screening, ongoing screening trials, the lessons learned, and then Praise You. So in the pre-screening area, 1 out of 2 to 3 patients died of prostate cancer. So it wasn't really a good diagnosis to get. And today, it's still the second most common cancer, and it is the 5th leading death among the world. So the incidence is still high, it is increasing, and it is important to tackle that. So to talk about the past, present, and future, I'm going to go back to the 80s. So in the 80s, as I said, pre-screening area, a lot of the men were diagnosed and died of their disease. It wasn't really good. Then in 1984, it was the introduction of PSA. The incidence massively increased. In 1993, the 2 main trials started. So ERSPC, so the European trial based in Rotterdam, it started actually a little bit before because they did pilots already before. And in the US, PLCO started. But officially, both started in the year 1993. And they both looked at prostate cancer mortality. In 2009, that was the first time when results were published, and that created massive controversies. So before, I would describe it as the golden age of PSA screening, because everybody was in favor of PSA. PSA was this new thing, which was great, and everybody did PSA tests. But then in 2009, ERSPC, they identified a risk reduction of 20% in prostate cancer-specific mortality. So they had clear results in favor of PSA screening and a 30% reduction of metastatic disease at diagnosis. However, the controversy started because of PLCO. They didn't see an effect. That started, as I said, the debate. And then in 2016, clarity was provided because the ERSPC and the PLCO trials both provided comparable evidence. That was because there was a lot of, in epidemiology, we say spillover. So in the cohort where you have the tested cohort and then you have the control group, a lot of the men in the control group, they actually received a PSA test. So you couldn't really use that result. So it was there was a meta-analysis and they did some testing and they came up with the same results. Because it's Praise You, I'm also going to talk about the political aspect, because for Praise You and the push, which is right now happening from the European Commission, the political view is quite important too. So in 1984, the FDA approved the first commercial immunoassay for PSA testing. In 2002, the United States Preventive Service Task Force, quite a long name, they published that the current evidence is insufficient. As you can see, 2002, nothing was published there yet. So the results from the big trials from ERSPC and PLCO wasn't even out, but they already recommended against routine screening. In 2010, the EIU recommended for individualized risk-based screening. So that was the start of a movement which is still ongoing. And then in 2012, because of the results, the US recommended against PSA testing. So that was a clear no. In 2017, the EIU recommended MPMI before prostate biopsy. In 2018, that's again a little bit more of a political approach now. The Europe Beating Cancer Plan was introduced, and that also, I guess you know, in your countries, they also now have introduced most often different cancer plans. In 2021, Hein van Poppel published a risk algorithm which helps in the screening approach and which has been adopted by the EIU as a recommendation. Then in 2022, that is kind of the switch or the change in PSA testing and the screening and the approach to it, because there has been still a little bit of debate, and I don't know if you're in favor, but many people are still not in favor, many people are in favor, so there's been a lot of going on. But the SAPIA, that's an evidence review body which recommends and does evidence reports for the European Commission, for the European Council, so for different European bodies. They were in favor of PSA testing and said they should explore the possibilities to screen for prostate cancer. And that is kind of where we're coming from, and this is how the movement started, again, for PSA testing. So the EU for Health call, which is a funding call, they started, and Praise You got the money and started into 2023, last April, and we're going to work on pilot sites. So that's, I guess, I'm going to talk about this later again, but this is the massive difference. From a policy situation, so in 2018, the US recommended individualized testing. The EIU, as I said, with the paper von Hein van Poppel, recommends a risk-based approach. And then, as I also said, the European Commission now expands their recommendation to look into prostate cancer screening. And that is what we're doing. So what are the ongoing screening trials? So ERSPC, I've talked about that, and PLCO quite a lot, but there's still loads going on. There's still big trials which are important. So there's in Germany ProBase with Peter Albers. It's a risk-adapted PSA screening based on baseline PSA at age 45 and 50. I don't know if you know, but there's a lot of debate also on the starting age. When should you start screening? What is the right age? So they are looking into that. Then there's ProScreen. They do a risk-adapted PSA screening with 4K score and MRI. Then there's the Göteborg 2 trial, PSA versus PSA plus MRI. And then there's Stockholm 3, MRI-targeted standard biopsy with the Stockholm 3 risk stratification. And then a little bit of a different approach is Reimagine, because they're doing a feasibility study. So they're testing in the population if MRI as a screening approach does work. On the contra side, I guess that is quite expensive, and you have to have the capacity to have that many MRIs to do that approach. So what are all those trials have in common? I said I used a mountain kind of approach, so there you see all the trials skiing down the mountain. And so what they have in common, there's a lot of debate, 30 years of history is going on, but those trials, they're all built on the history, on the 30 years of research and the 30 years of debate, and they're using new technologies. So the need right now and the new approach for PSA screening is to use a risk-adapted approach and not what we're doing right now, which is opportunistic screening, which is screening on a case-by-case basis, which is high in costs, and also, as we could see from the history, not effective. So what are the lessons learned? There are important things to consider when you're doing a PSA, a population-based approach. So the life expectancy should be 10 to 15 years at start, because otherwise you might run into over-treatment and over-diagnosis. We also learned that a yearly PSA test is too much. And you can see on the left side the algorithm from Hein van Poppel's paper, and there you can see if you are below 1, for example, then you should repeat PSA test after 5 years. So if you are a man at age 50 and then you do a PSA test, your PSA level is low, then you should only get a PSA test again after 5 years. That is the risk algorithm, and that tries to reduce over-treatment, and it tries to reduce over-diagnosis. And there are different approaches to it. And also, risk stratification is important. So if you have a higher than 3 PSA, then you should do further risk stratification. This man shouldn't be getting an MRI or a biopsy immediately. You should use a risk calculator. You should use, for example, the ERSPC risk calculator. They're using prostate volume, PSA, and then you can further classify, is that man at risk, is that man not at risk? So you should do different approaches to actually use PSA as a really important tool. The introduction of MRI also showed to result in a reduction of biopsy procedures. I've talked to a pathologist before, and he said screening, well, a lot of biopsies, that's going to be a burden on the healthcare system. But if you use a smart approach to actually doing the screening, that's going to change. So an MRI introduction after risk stratification of an MRI will reduce in reduction of biopsy procedures, better detection of low-risk prostate cancer, and then a better detection of high-risk prostate cancer. So you know more what you can do. And then the discussion of active surveillance, which has been going on also for, I guess, the last 10 years, that definitely reduces overtreatment and should be considered. So what have we learned from now? We went through several policy changes, which I showed you, the golden age of PSA screening. Everybody was against PSA screening and a lot of controversy also on the political level. And then we have the new evidence from the big trials, which are still ongoing, which we still need to use and learn from it. And then there are the new policy recommendations, which open a new window. So we can conclude that the PSA test in itself is a powerful risk stratification tool for establishing a baseline PSA among healthy men. I think that's also important because those men are not patients. We want to keep men healthy, and we want to we want to introduce that to healthy men, not the patient, not the one who comes to the practice and has already side effects or has some burden. We want to introduce it into a population to keep the population healthy. So a population-based approach deals with healthy men, and their PSA is a powerful risk stratification tool. Risk-adapted approach, I'm repeating myself with that. The big trials are still ongoing, and then the learnings need to be translated into a country-specific context, because what is working in the Netherlands might not be working in Slovenia. What is working in the UK is also a different healthcare system. There are different resources that might not be working in Germany. So you need to adapt the risk stratification, the risk approach to your country and understand what is happening. So that is where Praise You kind of comes in, because that is what we're trying to do. We Praise You, as I said, the coordinator is the EIU, so it gets a lot of political push. We're only working for 3 years, so it's only a really short time. We're a little bit under time pressure, to be honest, but it is a short time, and it is a sister project, so there are 2 other projects similar as Praise You going on in lung cancer and gastric cancer, because they went through similar journeys. The consortium is not that big. There are 25 institutions from 12 member states, but you can see the EIU is involved, ERSPC, so the whole trial community is involved, Erasmus MC, my university, and then also WONCA, which is, I guess, quite special because the primary care physicians are involved in that. That is basically the EIU of the primary care physicians. So they also have a say. They also are in the discussion, which is important. And then also the patients are important because that's the important voice we need to hear, and the WHO. So Praise You's mission is to assess the needs in the different European member states and to design a diagnostic strategy and algorithm for EU prostate cancer screening. And the important thing, it should be cost effective and also raise awareness, because that awareness is currently not there and it needs to change. We're trying to come up with tailored recommendation on a risk-based early detection strategy. And this ultimately will result in the discussion which is going on, which is about overdiagnosis and overtreatment. And this is not what we want. This is what we learned from the history, and that is what we want to avoid. How we're doing this? So I'm involved in Work Package 2, that's the Knowledge Hub. So we're trying to gather knowledge on what is happening in different countries, if there is opportunistic screening, so case-by-case screening and unnecessary screening. We want to understand what are the policies. Do the policies recommendations respond to the different guideline recommendations, or are they different? Do clinicians then actually follow those? What is happening, those legal recommendations, what is happening? And then we develop indicators for screening, which should be cost-effective. For the next work package, they're looking into the capacity assessment, so what is possible in what country, and what is the capacity in that country, quality assurance, and then also training tools to make people understand what they need to do and help them. The pilot studies, they're different pilots, and I'm going to go into that on the next slide. And those pilots, we're going to test in different countries. What is possible, what do they need, what is working, and we're going to evaluate on that. Is it cost-effective, sustainable, feasible, functionality, and yeah. So in terms of pilots, there are 2 in Spain. There's 1 in Lithuania, and Lithuania is a bit of a special case because currently they do have already a they have already a screening program, but it is not risk adapted. So right now what they're seeing is not really working. So they're working with PraisU to adapt that, what they're doing right now, and use a risk adapted approach to make it efficient and effective and get better results of it. Poland is also one of the countries, and then Ireland is also one. And I think, going back to that, is also important that we're using, there's already something going on in Sweden, they call it OPT, and that's so they do in different regions, they're testing. They have different protocols, and they do PSA testing. They're using an algorithm, a risk-based algorithm, and the results from them are quite good, and we're learning from their experiences how to do it. So that is a bit of a ask from us to you. So I don't know if you've already received the email from the EIU, but we've tried to promote this quite heavily. So we have a survey out because we want to understand what are the barriers to screening. So if your country has an interest in screening, and if something is happening in your country, we want to actually understand what are the barriers to actually implement a population-based screening program. Is it, for example, inadequate policy support? So do the government not support screening? And that's a massive barrier which will result in no success. But then also infrastructure. Do you have a population-based register? Because if you don't have a population-based register, how are you going to select those cases? And those are the barriers we're trying to understand, which then can be used on the PraisU level to promote what is happening in your country, but then it can also be used. There's a new call on joint action for the member states. So it is very much understanding what is going on. It is available in multiple languages. I learned yesterday that we only have Croatian because it's the 27 EU languages plus then Ukrainian. But I heard everybody does somehow understand Croatian, so you can use the Croatian version. So as a conclusion, we're building on our current knowledge, a long road of screening history in prostate cancer. We're still learning from important trials across Europe. We learned important lessons, risk-based approach, which I said before. And then PraisU offers a new opportunity to apply our learnings and continue to learn more outside of the trial setting, because we need to move on. And that is my QR code again, which brings you to the survey. So thank you very much, and I would appreciate if you fill in the survey.
So thank you very much for a very nice presentation. I didn't hear anything about Tyrol study, but I hope you involved it also, the results from the Tyrol study in your measurement. In any case, first presentation, you are very good in time, so we have enough time to discuss already now. For the other presentations, we will discuss later after the presentation, but if you have any questions, please do not hesitate to ask. Please, any questions? It's very important for the discussion. Is Austria also included in that?
In PraisU?
Yeah.
Not actively. Through the EIU, yes, but not as a pilot site.
Okay.
But if you want to, you can
You
reach
will send
out.
us this probability to be included. We have a lot of data from our screening, so it could be possible to work with. What is about digital rectal examination? I didn't saw anything about digital rectal. You talked about PSA calculations and about MRI. Is digital rectal examination still something which should be included?
Well, it is in, for example, the risk calculator and the ERSPC risk calculator, because if I'm wrong, that might be true, but a prostate volume you need a DRE for prostate volume, and that is the first step in the risk calculator. So you have PSA and DRE, and that gets you the first risk stratification in the first row. So yeah, it is still included, but it is less prominent in the discussion right now because it, I guess, is a standard, which is anyways.
And what do you tell? What is the cutoffs? Which cutoffs should be used in the PRAISE study?
So the cutoffs in the PRAISE study, that's what we are currently developing. So for now, we're using the Hein van Poppel risk adapted approach. So what is also right now recommended by the EIU. Yeah. But as I said, it needs to be translated into the country So we need to work with the country, understand what are the needs, and that's why we do the different needs assessments to understand what is the right age, what is the right cutoff for that population. But there shouldn't be everything fits everybody approach. It should be an individualized risk-based approach. So it should be tailored on your country, what is happening in your country, what are the healthy men in your country, and how is the burden of prostate cancer in your country, because that differs, as you know.
But it's only for EU, the other
Praise
countries?
you right now is mainly EU because it's EU funding and the political approach comes from the European Commission. But my boss, Professor Robol, always says EU plus. So because the EIU is more than just EU, it should be extended and can be extended. And
can be extended also for the countries from this region here.
And especially support, if you need support, if you're going to start a screening program, if there are discussions in your government that something like that should start, you should reach out to either me or Professor Robol or Hein van Poppe, because I'm sure, well, for me at least, but everybody else, and Praise You is there to support the different countries and to help. That's why we're trying to advocate, that's why we're so loud about it, that's why there are so many discussions about that, because it is an approach where we have to move on from what is happening right now to a new approach, and that is learning from the old past, implementing that in the future, and that is communication and collaboration across the region.
Okay, thank you very much. Other questions?
Who may be included in this project? Institution, Ministry of Health?
Depends. So there are, as I said, GPs. So for example, one pilot site is run from a GP site. But then there's also in the Czech Republic, I don't know if you're aware, they're starting their risk-based screening approach from a population-wide level there. And there we're working with the statistic office from the national government. So it really depends who's the stakeholder, who's driving that. But if you want to be the stakeholder who's driving that, and if you have the context in your country to move forward, then it could be you.
I will be difficult. In my country should be addressed to the Ministry of Health.
It depends on the country, yeah. That's why there needs to be always the individualized.
I will look at this site and I will send information to the Ministry.
Thank you, great, yeah. And if you need anything, please just reach out.
Yes, we have another question from Dr. Knežević.
Croatia, so should we already start discussion with Ministry of Health
Yeah.
about this program of screening? So we already in that process. So do this combination of MRI, PSA, and so it already starts to plan at the beginning of the next year to start this.
Great, that's really good to hear.
Any other questions? If not, thank you very much for the nice presentation, and we can discuss also after the section. So, we will idemo dalje, sad ću prebaciti se ponovo na materni jezik. Drugo predavanje je od doktora Marka Vukovića.